So it must be fairly late in the evening in New Delhi. So thank you for being with us.
Yes, it's 12:30 a.m. in the morning. And Fazila, good afternoon to you. I'm sure it's afternoon there. And we have some
And
interest.
I hope you're not too sleepy over there.
I just hope so. This case cannot make us sleep, so there is no question about that. So I briefly discussed this.
So please go ahead with your case introduction. And,
yeah, can we have the slides? So this patient is a 67-year-old gentleman. He presented to us yesterday evening with the acute onset of chest pain and breathlessness. And there is no past history of coronary disease. Next, please. So the first ECG done in the emergency room showed an ST elevation MI. You can see lead 3 more than lead 2 and has a right bundle branch block. So there was a clear-cut ST elevation MI. So he was shifted straight to the cath lab from the emergency room without any delays. And we were expecting the right coronary artery to be blocked. Can you go to the next one? So as we generally take the guide catheter for the culprit artery straight away, so we took the right guiding and the RCA was blocked distally. Next, please. So the wire was crossed, and you see the wire is in the PLV branch, and there is a tight lesion in the PDA and at the crux. Next. So 2 stents were deployed, one in the PDA 2.25 into 15, and a 2.75 into 22 Onyx stents were deployed and post-dilated with 3 millimeter balloon at the crux. And this was the result, which seemed pretty good, and the pain got relieved immediately. Next. Then we went on to take the left coronary shots, and you see that there is some disease in the osteoproximal region of the LAD. The circumflex appears to be normal. Next. And the AP cranial view shows a tight lesion in the distal parts out of the LAD. And next, please. This is the LAO caudal projection. You can see the ostium of that LAD. If you look at the osteoma circumflex, there appears to be some disease, which, even though mild, there's a small ramus right in the middle of this disease. So today, our focus is going to be the left coronary artery. And I'm going to look forward to some suggestions before we start and tell you what we are doing and what we have done so far.
So quickly, maybe Dr. Singh, I'll get some comments from my panel first. Tegu, you have some comments on this case. So with me on the panel is Dr. Lee as well as Tegu from Indonesia.
Yeah, I think the right coronary artery has been addressed successfully, and the circ is normal. So what I see here is probably a significant lesion, the proximal LAD, and there is also a lesion, the mid LAD. So I think we can do IVUS, and then we may have to fix the lesion, the mid LAD, and also the proximal LAD, depending on the IVUS finding. The lesion in the mid LAD seems to be critical, and in the ostial LAD, the options are, first, if you have a DCA, of course, this is a good case for DCA. And second, if we don't, then probably we can implant a stent, crossover from the LAD to the lamin, crossing over the circ ostium, because the circ ostium seems to be healthy.
Right.
Dr. Lee,
with a lesion like this one, though, the ostium or circumference is not critical enough. Most of the time, when the LAD ostium is treated with a stent, and the plaque shift will occur, and the danger the circumflex. So in these cases, I would treat it with the 2-stent technique. But given there was a size discrepancy between the lamin and the LAD, I would do the IVUS check first to see whether the stent could be expanded to the lamin size.
Okay, so I think what I'm hearing is that most operators would favor treating the osteo LAD, and the technique is probably a provisional since the osteo looks pretty decent. I just have some comments about the functional significance of the osteo LAD and some of the size is matched. I think maybe even the IVUS or FFR assessment or osteo LAD lesion may be warranted after treating a distal LAD. to give you more grounds to send the left main here. Fazila, yes.
So I'd be more interested to see what you have done so far, Dr. Balbir
Right.
Singh. I assume that you have
Can
done
we
a
go
bit
back to the
of-
slides?
Yes. So could you show us what
So
you've done?
yesterday, as we just got in, one of the panelists thought that FFR should be done. So we did an FFR yesterday evening itself. And I will show you the FFR results. Next, please. Can you show the FFR, please? So briefly, I'll tell you that resting PDA-PA ratio, you can see that in the distal lesion is 0.44, which is quite sure it was very tight distal lesion. And even in the proximal area, we got a PDA-PA of about 0.79, 0.8. And after adenosine, the FFR was 0.76, telling us that this lesion is pretty significant to start with. So we have taken the patient in today to address the left system. We have first fixed the distal part of the LAD. Can you show today's angiogram? Right from the beginning. So this is the angiogram of today. You can see the proximal part of the LAD shows a significant lesion. The other important thing is that if you look at the size of the left main, it looks smaller than the circumflex. So these are some of the clues that the left main is involved. And of course, after the two diagonals, you see a tight lesion in the LAD. So this is the ostium part of the of the LAD. And you see a ramus coming out, which is right in the center. And then there's a good angle and circumflex comes out. Next. So this measurement is about 30 millimeters. If you take the ostium into consideration, we would probably need a 34 or 38 stent here. Next. So we went ahead and dilated the distal part of the LAD and placed a 2.25 into 18 onyx stent here. Next. You see that it's not fully expanded in the proximal part. Then we went on to do high pressure dilatations at this point and achieved this result, which is pretty reasonable. I think I would accept that result. And now we are trying to focus on the proximal LAD and left main. So as we said, there is a huge disparity between the size of these vessels, LAD and left main. So without imaging, this would be a futile exercise. So we chose to do OCT. And Vijay is here with me. He's one of our experts on IVUS and OCTs. So he's going to discuss we've taken a pullback from the LAD and also from the circumflex. So we have OCT, 3D OCT images, and he's going to discuss. Vijay.
Yeah, good afternoon. Here we can just we can see that pullback from LAD to left main.
Can you see the OCT images? Yeah.
Yes, we can.
Yeah.
We can.
So this is a diagonal branch, major diagonal branch, where we find a landing zone close to this diagonal branch angiographically. And when we imaged with OCT here, you can just see we are able to see almost 360 degree of vessel. And even though there is some plaque and it is all very stable, fibrous looking plaque and little bit of calcium. And if you come a bit proximally, there is a lot of plaque, there is increasing. You can just see here, there is a calcium, big chunk of calcium here and a small island, another island of calcium here. And lumen looks pretty okay here. And if you come proximally, again, you can just see a bit of calcium and a lot of fibrous appearing plaque. And this is the tightest part of the lesion with a lumen area of 2.48 millimeters square. But anyway, we have already done an FFR that was positive for ischemia. And here you see there is a calcium here, nearly 180 degree of calcium. And we come proximally, and again, plaque here, the disease extends close to the ostium. And this is again the narrowest part close to the ostium here. And if we come to the left main, we all know from the previous studies from Mehran et al. And whenever you have an ostial LAD disease, there is always a distal left main disease. And it is true here, even though lumen appears big and it is about 10 millimeters square, and you can see a lot of plaque. And unfortunately, from LAD pullback, even though we got the distal left main, we are not able to see the ostial left main lesion here. And whatever measurements I could get, left main is 5.4 millimeter vessel with a lumen of 3.8 millimeter diameter. And after getting this information from LAD, and we measure the length, whatever extent we could see the left main, it is 35.4 millimeters. So most probably we'll be taking a 38 millimeter stent to extend to the left main ostium. and quickly go to the 3D bifurcation. And angiographically, we know there are two branches. One is this LCX, and then there is a ramus here. And images are not very clear. If you see that this is the ramus branch, and here we have LCX branch. And the angle, whatever we could see, the LCX is highly unlikely to be compromised. And if at all it is compromised, it is most probably the ramus branch. So because you can just see this carina is extending across the ramus branch, so most probably we'll be leaving the wire in the ramus rather than in LCX.
And just got it.
And we went on
Just a
to...
question,
Yeah.
Dr. Singh, is OCT your, is OCT your preferred mode of imaging to do a complex left main PCI, or do you use IVUS as well?
So we do both, and the ostium of the LED left main is the only caveat which is not seen well with the OCT. But in a distal left main case like this, I would be pretty okay using an OCT. So now you saw the calcium, and as was discussed, we have an ostial LED. We have chosen a scoring balloon to dilate this lesion. So I have taken a 3.0 into 15 millimeter angioscult, and I'm going to dilate this lesion well before we think of putting in the stent.
And we'll show that LCX.
Yeah, so Dr. Vijay is going to show you the LCX while I do this
Did you do a
preparation.
pullback from the LCA?
Yeah,
Yes, we'll do that.
We did that. And the
show you.
LCX ostium is widely open, and it is a 3 millimeter lumen, so it is highly unlikely to be compromised. And we could get a good image of left main here. You can just see there is a diffuse block in the left main, and left main is about 8 millimeter in length. And if you see the ostium, it is an eccentric disease. You can just see a lot of plaque here. And even when we attempted to engage the artery during the initial diagnostic imaging, we had a dampening. So most probably the left main ostium also diseased. So we are planning to extend the stent to the left main ostium.
8, 10, 12.
Sorry, is this a pullback from LCX?
Yeah, it's a pullback. What you are seeing on the
Because we
screen
need
is
to
left
do a
main ostium, almost
double
close to the
pullback,
ostium.
one from the LED to the left main
Yeah,
and the
yeah.
other one.
Yeah, because it's a bifurcation disease, then we just wanted to be sure about LCX ostium. But if you see here, the LCX ostium is well
10,
open.
12.
This is LCX ostium. And if you see the
Down.
measurements, it is a
I think
7
that's
point.
the challenge of OCT in this case, because the ostium of the left main, you're still not too sure whether that's a true ostium measure.
Yeah, just see, this is the part we got. Can you see here? This is the left main ostium, most probably lit.
Down.
And even though area is
12, 14.
big, and but there is a lot of disease. So we thought we
16,
had to extend into the
18.
ostium,
Down.
into the aorta.
So you would see that I had placed the wire in the ramus because of the fear of closure of ramus more than the circumflex. After the pullback, we placed the wire in the ramus to dilate. Now I have chosen angioscult, and we could go on high pressure to get a full inflation on the balloon. Can you show the last angio? So there was a slight waste with, on high pressures. This waste went away.
So, Dr. Singh, can you share with us your thoughts about what you saw on the OCT? How does it help you with the intervention?
Yes, right.
Meaning,
So, right.
you have a 34, 38 mm lesion,
Yeah.
and the distal reference diameter looks about 3035, but the left main is about 50.
3.5.
Yeah.
Are you using one stent, two stents, or
Okay. So I have chosen an onyx
can you
stent.
share with us?
So I'm choosing a one stent because I've chosen a stent which we can expand to 4.5 to 5. I'm taking an onyx 3.5 38, which will be able to expand to 4.5 easily, and maybe 5 if need be. So that's what we plan to do. And I'm going to cover the left main ostium for sure, because even if we have not seen it, there's no point leaving the stent a millimeter inside the left main.
Dr. stent. Does it make a difference for you to use the regular balloon over the scalp?
Yeah, so
Calcium.
A regular NC balloon.
regular NC balloon versus angioscult.
Because we could see 180 degree of calcium.
Because
and
we saw a lot of calcium, so either it was using an atherectomy, which is not available in our country, or using a scoring balloon. So I preferred to use that. So the other choice was to use a cutting balloon, but with so much calcium, I think angioscult is safer. Elio call.
So, Dr. Singh, I see your preferred view for covering the osteo LAD is a caudal view.
No, I will go to eleocranial as well. Cranial.
What
Eleocranial.
is your view of preference to assure that your proximal end of the stent covers the ostium of the left
Right.
knee?
So my guiding was getting wedged.
Best view in your opinion?
In my opinion, eleocranial.
I usually use PA cranial and just simple LAO.
Okay.
Another important thing is that if we are using a long stent like this, especially if the lesion even longer than this in your country, for example, you have the longest stent in the world, 60 millimeter stent, tapered stent. One thing that we have to consider is the left ventricular function, because if we inflate or deflate a long stent, then it will take time. So if the left ventricular function is compromised, we have to be very careful with
Okay, go up.
ischemia, with
10,
inducing ischemia of the global
12.
ischemia of the left ventricle.
That's also a very important learning point. I mean, keep the inflation short, right, Dr. Santoso?
Down.
And Dr. Santoso, how often do you use a cuspal wire to identify the ostia if you're doing a left main? I was asking you, do you use a cuspal wire to identify that you don't use that?
I don't normally use that kind of wire. I don't like using extra wire or the blood pedal technique.
So I think the
4.5.
advantage of using the LAP cranial or L cranial allows you to really make sure you cover the ostium, because you will have some protrusion because of the angle, but you just want to make sure you don't miss the ostium.
Eleocranial या epicranial.
The current
Shallow
generation
in
of stent is usually very easy to
थोड़ा सा elio.
be
So we have 10 minutes remaining.
Okay.
So Jack, would you be using two stents, use a 5 millimeter stent for the left main and a
Are you correct?
more smaller stent for the rest of the LAD, or are you happy with just using a long stent and then optimizing the size?
It's probably cheaper to use one stent.
That's an important point. It's cheaper.
The only point about the one stent technique is that if you want to cover the ostium and you are going to do a proximal post-dilation of the 5 mm, sometimes there is a little bit of shortening that you have to be aware of. So you probably have to protrude a little bit more with a 3.5 stent. I think most of the 3.5 platform can go up to 4.75 nowadays. So, yeah, I think.
Go. 10, 12, 14. Down.
What size balloon is it?
I have taken a 4.5 into
You're doing
8.
flaring, like?
Yes. Into 8. Heliocaudal. $12. Down. So we will now take an OCT pullback. And assess both LAD and circumflex.
Quickly get a lumen profiles to see this.
Regarding the guide catheter for lemon stenting, I would ask the panels, is there any personal favorite guide catheter doing this intervention? Dr. Sengoso?
I normally like to use extra backup catheter, just like this.
Myself, the same.
I think I'll ask the operator to use whatever they're comfortable with. I personally just use extra backup for most cases because sometimes you never know what you need.
I just want to give a short comment regarding the use of a small balloon or a short balloon to flaring in the ostium. Normally in my practice, before we pull the balloon out of the coronary catheter, while the balloon is half deflated, I introduce the guiding catheter into the left main. With this, I will protect the proximal end of the stent because the current generation of stent is normally is very thin, like in between 60 to 81 micron. So if we are not very careful, we can induce a concertina effect or accordion effect in the proximal or damage the proximal end of the stent. So before the balloon is fully deflated, I introduce the balloon in because the guiding catheter in because we know that the left main diameter is already big enough to accommodate the guiding catheter.
Safe.
Yeah, that's a very good point.
I think that's a brilliant suggestion, and I also often do that because if you're not careful, you can easily damage the stent which is coming up to the ostia with your guide catheter. So one has to be very, very cautious and careful while they're doing a left main PCI and the stent is coming up to the ostia. And that's a great suggestion.
Right. So we have taken an OCT pullback from the LAD to left main. And this time I have been able to include the ostium because the guide was just pulled out at the last minute.
Left main part we are not able to see clearly. It's in
So it appears that it has been well opposed. Now I'm going to cross to the circumflex side and try to get a pullback from the circumflex because the ostium of the circumflex is extremely important.
We don't have to do it. Circumflex.
Can you see the circumflex?
Yeah, we can see. It is good.
So we'll first analyze what we have seen right till now.
So
Vijay, can you?
We've got 5 minutes left.
Yeah.
So we'll just discuss what we have done so far.
So here you can just see the distal part of the stent. It has landed in a reasonable area. This is your diagonal, and it is landed proximal to the diagonal. There is no edge dissection, and reference zone looks big, and you're coming proximally. So this area looks little smaller and come proximally a bit more. Just we quickly see the ostial LAD and come back to the measurements. And the ostial LAD looks okay. And you can just see the circumflex here. It is wide open.
Yeah.
It is wide open. And left main part, unfortunately, we haven't got good images. But whatever we could see, LAD part of the stent is okay, and L6 is wide open. And I'll get you some measurements. lumen
So I'll take a
In the longitudinal view, it seems that there is some narrowing in the left main ostium.
Yeah, yeah. So this is distal part of the stent, and we come to the ostial LAD, and the minimal lumen area in this part is 6 millimeter square, and looks reasonably okay. Anyway, we are going to do further optimization with a 3.5 balloon, and unfortunately, we don't have much of left main information here.
See, what is seen in the longitudinal view is not good because there is a lot of blood spill in that area. I pulled out the guiding trying to see the left main.
And this is LCX part, it is wide open, so there's no compromise, no carina shift at all.
So in view of the shortage of time, I'm going to optimize the LED stent, but I'm going to show you the angiographic result before we finish off. So this is the angiographic picture. The left main stent seems to be nicely flared up. The ostium of LED will need some more dilatation with a 3.5 millimeter balloon. And the circ ostium appears really good. So I'm not going to do a kissing balloon or another stent. So how many on the panel think a kissing is a must here? Or we can just go ahead and finish this case?
We have 2 minutes left.
Yeah, I think we have 2 minutes. Maybe Dr. Singh, I will ask you to just summarize your main points of the case and what do you think are teachable moments in this procedure?
So the main points are, this was an acute myocardial infarction happened yesterday, and we have addressed the non-culprit lesion, as is the data from the COMPARE trial and the other two randomized trial, which suggest that if you do a non-culprit PCI within 72 hours, the MACE and the death rates are lower. So we used FFR to guide our ostial lesion because FFR proved that it was significant. And imaging, we could have chosen an IVUS. For technical reasons, we had to choose an OCT. The calcium helped us choose a scoring balloon. The MLA at the ostium is 6. I want to hope I can make it 7. And I went with one stent strategy, which I think is the right thing because we had seen the circ ostium on OCT. So that's what I would summarize this case to be.
Congratulations, Dr. Singh. I think it was a very nice demonstration for a crossover professional stenting technique. You also highlighted the use of both imaging as well as functional assessment in this case. Very nicely done in a very short space of time. And I'm sure you're going to further beautify the results on this case. The only point I have about the imaging is that when I suspect I'm doing a left main intervention, I do prefer IVUS over CT though. You never know where you need to look at the osteo or the left main. With that, I think the time is up. Thank you very much.
Congratulations and a great case.
Thank you, Dr. Fazla. Thank you very much.